So I simply titled this one Explaining EXSTORE, because what this is doing, this is a great lecture, webinar for those who have never heard of EXSTORE, who have heard of it and want to learn more about it, for those who treat musculoskeletal disorders, and for those who actively practice it, to look at it from a different perspective. And the keys to EXSTORE is that really, if I had to encapsulate it in one line, it would be think less. Don't overthink. All right, we're going to keep that. We're going to come back to it. So explaining EXSTORE. First, I want to talk about vocabulary goals that I don't like that practitioners say to patients when they're treating MSK. You should ban these words from your vocabulary, or don't say them at all, because you really shouldn't be saying these words. And Josh alluded to it earlier, because we want to build certainty. Clinicians, if you're a clinician, especially if you've been practicing for a while, especially if you see more so MSK cases, you should be treating with certainty. And if you're not, you need to rethink things, because you need to get better. There's no reason we should be using the following words. Might. I think this might work. Maybe if we try this, I think we can get more range of motion. Hopefully over the next couple of treatments, this will help your shoulder pain. You know, we could try this treatment. This really should work if we apply it correctly and if you do your home exercises. Well, we'll see if this works. Let's see if this works. I never say these words. I never, ever say these words. I either tell them, look, we can try it, but it's probably not going to work. Or I tell them, you're going to get better, because the more you treat patients, the more you follow a system, the more you know. There is no guesswork. Sometimes you get surprised by things, and it's okay to get surprised by things. Sometimes you might think that, hey, this is going to take a lot of treatments and it takes a lot less. Sometimes you think it's going to take 3 or 4 and it takes longer, but there's a reason it takes longer, because they have an underlying condition, and we cover all of that in EXSTORE. So let me give you a surface level taste of this to really open your mind, because this is what it is. It's a mind opening system. So what we need is to provide positive and definitive vocabulary. And when we do our history, the EXSTORE assessment, these clearly tells us the type of problem being presented. It clearly tells us if it's a mechanical problem or if it's a problem that has pain, that has an underlying systemic condition. Many people don't understand. There's a huge difference in your approach, and there's a huge difference in clinical results by understanding, is it a mechanical problem, or is the problem complemented by an existing condition, a shoulder problem and the patient has diabetes, a shoulder problem and the patient has rheumatoid arthritis, or an autoimmune inflammatory arthropathy, something like that, or they have depression, or they're addicted to painkillers, or they have fibromyalgia, which is a cornucopia of many system irregularities. So we only recommend something and perform it if we know it is going to help, not if we think or hope it might help them. Now, people are saying, well, wait a minute, I just started practicing, I graduated. How am I supposed to know with certainty that something is going to help? That's impossible. And you're absolutely right. That is impossible. But we can put you on track to make your predictions very high percentage. And it doesn't take a lot, because I've simplified things. And there's many people who give a lot of testimonials who've been practicing for a very short time because they follow the system. And the great thing about the system, it's red flag proof. It always falls back on, is this a red flag? Is what I'm looking at normal, or is it abnormal? And whenever we are in practice, we don't necessarily have to know what's wrong. We just have to know that it's different. we have to be able to recognize that red flag. So the great thing about EXSTORE, it allows us to streamline, but it also allows us to raise the flag if we see it early on. So we always do something for a reason. We never do it just to try or just to see, or maybe, or it could, or maybe, you know what, maybe it might. Never, ever say that. Clinicians don't say that. If I went to a mechanic that said, well, if we change the transmission, your car might work, right? If we change your tires, your car might drive straight. No, no, no. You are in a position that you need to know. And once you know, that's when you build proficiency and confidence, and the referrals just keep piling up. All right. So EXSTORE is making observations without labels. We're going to play a game here. This is going to seem silly, but really, really think about labels and names. Do we really need them? Right? And especially in musculoskeletal care, patients come in and say, I have lateral epicondylitis. I have a disc problem. I have knee bursitis. I have rotator cuff tear. These things mean absolutely nothing, especially if you haven't assessed them. They are just labels without merit. Let's do a quick exercise. What the heck, right? All right, what is this? Anybody want to put in the chat, what is this here? All right. Well, most people are going to say what? It's a tree, right? But the thing is, here's the problem. That's also a tree. So if I say this is a tree, or if I say lateral epicondylitis or knee bursitis or rotator cuff tear, what does that really tell us? It doesn't tell us anything, because that's a tree too. It's the tallest tree in New York, by the way. And what does it tell us? It tells us nothing. Everything has to come down to observations and descriptions. And we don't know the level or depth of the problem until we get to assess it ourselves. And the trick is, assessment is much easier than you think. And pain, the location of pain is the consequence of the problem and not the cause in a musculoskeletal condition. This is a car, right? This is a car. I have sciatica. This is a car. I have pain going down my leg. I have pain going down my leg. Oh, well, this is a lot different pain. So how do we know it's coming from your disc? How do we know it's not coming from the gluteus minimus? How do we know it's just not referred pain from the SI joint? How do we know it's not coming from the hamstring that's compressing a branch of the sciatic nerve? This is an El Camino, by the way, 1986. These are very rare. It's a pickup truck and a car all together. This area back here is not a flatbed. What would you call it? It's the box. Excuse me. This is a chair. It has 4 legs. This is another chair, but it's round. This is a chair and it has wheels. You get my point, right? This is a fish. It's a sturgeon. In Canada, they just caught a sturgeon that's 10 feet long. All right? 10, I don't know if any of you read about this. These sturgeons lived, they think this fish is 110 years old. 110 years old. And here is where they actually use the eggs. This is sad, but if you eat caviar, and I don't, but they get it from, here in Canada, they get them from the sturgeons. But that's a fish, that's a goldfish, which is not a sturgeon. That's a, I'm not sure what that is. A trout. No, I think it's a trout. My point is, make observations. So when we use EXSTORE, we make observations. We don't come to conclusions, because our observations could mean something or it could mean nothing at all. Let's get into it. So first, a little bit about EXSTORE. I created it. I wrote a book, which many of you have. It's a manual. It's on drlombardi.com. When you, I believe you do get it when you take the live course, as well as auxiliary material. Created in 2010. I first taught it in Hamilton in 2011. It's now on 6 continents, believe it or not. I think we're up to almost 1,000. Actually, I think we're over 1,100 practitioners in 41 countries. To give you a little bit of a background about who I am and what I'm going to do after this, I'm going to post my on the Facebook page and on Locals, which I have already, but on the Facebook page, the EXSTORE Facebook page, I'm going to post my CV. So just for you, some of you who don't know who I am, to kind of see my credentials, my background, where I come from, and just to show that I have merit and I can really help you. And I've been helping many practitioners. And not only that, but in my practice, and I practice full time, I've been averaging for the last 11 years, and this is no joke, 12 patients per week. So it's constant referral. And I think this length of time demonstrates that if you provide good results, you can trust your patient base to take care of you if you take care of them. 11 years, that's a pretty significant body of evidence and still going. So results equal referrals. So this is your expectations. I'm going to say this, and I want you to understand that I'm not joking at all. With respect to a mechanical condition, and we're going to touch on the difference between a mechanical and a chronic systemic condition. Patient comes in, let's say with the shoulder problem, uncomplicated, mechanical, no chronic systemic, you should be getting an 85% improvement after the first visit. If you're not getting 85% at least after the first visit for any type of non-complicated mechanical problem, then you need to look for an avenue to help you get better. There's no reason why any of us can't get 85% after a mechanical problem. I know some people are probably shaking their heads saying that's crazy. It's not crazy. It's pinpoint. That's what you should be doing. And it's combination wise. It's not just using needles. It's not just using joint manipulation. It's using acupuncture. It's using soft tissue work. But more importantly, it's knowing where to treat and streamlining your time to get to the areas you need to get to like that. And that's where the EXSTORE system comes in, because ideally you will locate inhibitions and know what needs to be treated. The EXSTORE scan, the EXSTORE system, the assessment system takes about 1 or 2 minutes. And even that, it's much closer to 1 minute. We're talking 60 seconds, which means you have more time to spend on treatment, soft tissue, breaking up scar tissue, stimulating and activating inhibited muscles, improving range of motion. It is a gift. The greatest gift that you have as practitioners is knowledge and then time. If you know what's going on and now you have more time, wow, look out. And that's why I get those referrals. That's why we get people like Moses and Lev Furman and all these, John Cougar, Jamie Hampton, they're getting top quality results in their respective fields because they have the knowledge and then they utilize the time. So what is EXSTORE? It means examine and restore. So we reveal muscles that are shut off, or motor inhibition. And motor inhibition is when a muscle works suboptimally. And we're going to go through the 3 reasons why muscles shut off, but it's motor inhibition that is responsible for movement and stability of the skeletal girdles, the scapular girdle and the pelvic girdle. The game plan is to determine right off the bat in the history, is it a mechanical problem or a chronic systemic problem? So mechanical problem would be a problem with movement, a problem with strength, or both. Chronic systemic would mean something like an inflammatory arthropathy, a neuropathy, diabetic neuropathy, fibromyalgia, ongoing chronic pain associated with depression, overuse of opioids, inability to sleep, et cetera, et cetera. What is motor inhibition? Motor inhibition is the dysfunction at the point where the nerve attaches to the muscle. So it's called the neuromuscular junction. And there's 3 causes of motor inhibition: pain, trauma or repetitive trauma. So whether someone body checks me into the boards or I just am constantly typing and with bad mechanics, that repetitive strain is going to cause particular muscles to become inhibited, meaning that the constant noxious stimulus causes the motor nerve to work suboptimally. And the last one is changes in the joint. That's either any tears in cartilage or arthritic changes. So this is how it works. If we have the muscle and the joint, we have nociception coming from the joint or being stimulated, and that goes along the sensory neuron into the synapse, into the level of the spinal cord, to simplify it. And what goes in the sensory neuron gets spit out the motor neuron. So garbage in equals garbage out. And that causes motor inhibition. So in this bicyclical diagram, we can see a little bit more. So we have, for example, motor inhibition is caused by noxious stimulus, but then motor inhibition causes noxious stimulus, which causes neurogenic inflammation, which causes muscle weakness and adaptation, which causes more motor inhibition. So the key to EXSTORE is three things. We find what isn't working. So we assess, takes 1 or 2 minutes after the history. And the history is very pinpoint because in the first visit, you have the patient history that they write. So right away, you have a great understanding and idea as to what's going on. We really cover this in depth in the live EXSTORE course. Then you go through the assessment part, and then you find what isn't working and correct it using the acupuncture. And then you use the soft tissue work to restructure, to break up scar tissue, to improve the function, remove adhesions. So it's assess, neuromodulate, and restructure. That's EXSTORE. So I want to talk about the autonomic nervous system because traditional treatments, and I don't just mean acupuncture, I mean, let's talk about chiropractic. All right. Let's talk about chiropractic. Let's talk about the use of acupuncture and its relationship to the autonomic nervous system. This is the reason why acupuncture, traditional distal points, as an example, traditional mirroring approaches or approaches where we don't focus directly on the problem to treat the problem. For example, someone has a shoulder problem and they'll use distal points or auricular points or different methods in order to treat it because that's what they've been taught. Or chiropractors that'll have a patient with a shoulder problem that'll just adjust the cervical spine and the thoracic spine, and they'll keep doing that over and over and over again. So a chiropractor might say, well, I treated the patient 25, 30 times and they got better. And a traditional acupuncturist might say, well, I used these methods and they got better, say in student clinic after 3 months. They're not wrong. What those treatments do is they neuromodulate the autonomic nervous system. Acupuncture has a direct effect on the sympathetic and the parasympathetic nervous system. So if someone is anxious, there's points that will help calm them down. If someone is nauseous, right, GV26, that'll help prevent you from throwing up or make you less nauseous. Or if someone has a headache, GV20. Or if someone has pain, you can use an auricular point, you can use a distal point. All right, you can use different methods. Okay, and that helps. Why? Because we've neuromodulated the autonomic nervous system. The thing is, when we're dealing with a mechanical problem, it's not that that's not working, it's that it's taking too long. Patients sometimes don't have the time or the money to come for 30 times, right? It's much more attractive. It's sexier if you can fix the patient in, or when I say fix the patient, dramatic improvement in 1 or 2 visits. Then you can use all those other methods, which is what we teach in the EXSTORE system, to break up the scar tissue, to work on neuromodulating the autonomics, to improving perfusion. But you've got them already because right away you've made instantaneous changes. That's the key. In manipulation, we know manipulation stimulates parasympathetic function, right? There's many studies where they use the tibial reflex, the Hoffman's reflex, where they they see that after the manipulation, there is a activation of the parasympathetic nervous system. It works great. That's why I use it to complement my treatment in practice, especially over autonomic segments, T1 to T5 and T10 to L2. But if we just use chiropractic, it would take forever, and it usually does. But that isn't the best way. The best way is to get them in there as fast as possible, to make them say, wow, my mind is blown, and to refer you loads and loads of new patients. So how EXSTORE works. The premise, and I have a video to describe it, is essentially we take the scapular girdle and the pelvic girdle, and we assess the movement and stability of the muscles that stabilize each respective girdle. Now, I'm going to, Josh, I'm going to show you the video. Let me just do this. Okay, I'm going to use this model to demonstrate the goals of the EXSTORE system. Remember, EXSTORE system is not orthopedic testing. Although orthopedic testing has their place, the EXSTORE system focuses on observation of musculoskeletal movement and strength assessment with respect to two things: the scapular girdle and the pelvic girdle. The EXSTORE system has an upper and a lower body scan that tests the muscles that stabilize each respective girdle. You will find during a neck injury, a shoulder injury, an upper extremity injury, you will have inhibition of the muscles in and around the scapular girdle and the glenohumeral joint. When you have a low back problem, a knee problem, a hip problem, an ankle problem, you will have inhibitions of muscles that stabilize the pelvic girdle. And sometimes you will have both when you assess athletes that have compound movements, like a tennis player, basketball player, any throwing motions. So keep this in mind. This is what we need to do. This is why it's so simple, the EXSTORE system, because we are simply looking at the muscles that stabilize the girdles. For example, one big muscle that's tested is the serratus anterior. Look at the vast topography of the serratus anterior from ribs 2 to 9. And of course, that goes underneath the scapula, attaches to the rhomboid, which is underneath the middle trapezius. So in the system, we cover all of this, and in time, you'll see that the assessment takes seconds. 1 to 2 minutes to start, even less, so you have more time on treatment. I don't know if you noticed this, but this guy doesn't have a jaw, right? So it doesn't usually work like this. So anyway, it fell off. I just wanted to show you this, the jaw. It goes right here. Anyway, thanks for your time. All right, now we're going to go into some case studies, and I'm going to show you this is how the cases should be presented and how you need to think when approaching. These cases are taken right from the manual itself. First, a quote, and this quote, there's a series of quotes here. This was from, remember, this was written in when I first wrote the first manual in the first edition in 2010. Nietzsche, in the Clinical Journal of Pain, concluded nociceptive motor inhibition might prevent effective motor retraining. Makes sense. How many people go to rehabilitation, whether it's physiotherapy or physical therapy? And look, they're going there because their physician told them to go there. But they're going there and they're doing exercise after exercise, but they're doing it and their muscle is working suboptimally. They're never getting maximum results. And many times they're saying, well, I don't think it's working, or they just get to the point where they don't feel pain anymore because they become so inactive that they just don't move and they don't feel pain. Ingersoll in Rehab Management concluded, without removing or reducing arthrogenous muscle inhibition, rehabilitation may essentially begin after healing occurs. We might also reduce long-term consequences associated with muscle inhibition, including susceptibility to further or other injuries. Of course, if you haven't activated all the muscles, if you're still working with muscles that are for the most part, inhibited, you are putting yourself at higher risk of injury, especially if you are active. And sedentary et al. In the Journal of Athletic Training summarize treatments that have been shown to reverse the effects of arthrogenous muscle inhibition should be used immediately before therapeutic exercise is performed in an effort to activate motor units that may have previously been inhibited. How simple is this, right? If a muscle is shut off, if we know that inhibition is caused by pain, trauma, repetitive trauma, or changes in the joint, and we know it's in shut off, why would we be doing exercises first when we need to activate the muscle first? And the things that activate muscle are deep tissue manipulation, but the biggest one, electro-acupuncture, needling, electro-acupuncture, even needling without acupuncture, without stimulation. And there's a laundry list of references in the EXSTORE manual that demonstrates the activation of inhibited muscles. That is key. That is number one. So it's not fully embraced because tradition is embraced. When a physician says, all right, here, you need PT, and you go, or the patient goes, because it's reflexive. Just get it in my office, right? That's how it works, unfortunately. But we're changing it. How do we change it? Through amazing results. Nothing replaces amazing results. Nothing. Case one. A 25-year-old female presents with right tennis elbow pain of 4 months duration. She is a competitive squash player and has had to modify her stroke to compensate for her elbow pain. Medication and NSAIDs give her temporary release. The EXSTORE system reveals on gait analysis that her right arm swings considerably less than her left, and her right trapezius is elevated during gait. The upper body scan reveals her cervical rotation is 45 degrees on visual inspection, and lateral flexion is limited to the right. Marked weakness occurs upon testing of the supraspinatus in both positions, and her serratus anterior is inhibited on the right, that should say. Typical diagnosis when someone presents like this is, well, that patient has right tennis elbow, and we're going to treat the location of pain. So traditionally, it would be massage the elbow. It would be put needles in the elbow. It would be ultrasound on the elbow, tape the elbow, kinesiotape the elbow, right? But that's the consequence and not the cost, because we know tennis is a compound movement. How you see this history written up is how you would want to deliver the results of your assessment. This was observation. If you look at this paragraph, it's all observation. It's what you notice, and you're not drawing conclusions. We never once draw conclusions. This is how we articulate this presentation without putting a label on it. And when we don't put a label on it, we can openly have discussions with other practitioners, because you're giving them a working diagnosis. Because just because the patient has pain on their right elbow doesn't mean that it's tennis elbow. It just means that it's elbow pain. EXSTORE approach, this is how we articulate it. We have right lateral elbow pain associated with limited right cervical spine rotation and lateral flexion, weakness of the supraspinatus and serratus anterior muscles. We need to restore motor inhibition of the scapular girdle and supraspinatus using manual soft tissue technique, or like acupuncture, manual soft tissue technique like acupuncture or muscle release, then focus on restoring dysfunction of the cervical spine. Do not address the area of pain until this has been addressed. So until we restore the motor inhibitions found in the EXSTORE scan, we don't go anywhere near the elbow. We don't. That's the difference. Look how comprehensive this is. And I have news for you. This comprehensive expression of what's going on is extremely easy, because I give you a checklist. And from the checklist, you combine and create the narrative. Case number 2, interpreting your results. A 65-year-old male with moderate degenerative osteoarthritis in his lumbar spine presents with left lateral knee pain. Patient presents with good overall health, blood work is unremarkable, and X-ray reveals mild osteoarthritis in his left knee. The EXSTORE system reveals a mild antalgic limp during gait analysis, very little pelvis rotation during gait. The lower body scan, that's the EXSTORE scan, reveals that standing lumbar extension is limited due to mild pain. And upon strength testing of his oblique and transverse abdominis muscles, he can't stabilize his lumbar spine during resisted lumbar rotation. The abductors in the pelvic girdle, that means moving the leg away from the midline, are inhibited on the right during stability testing. Typical diagnosis would be left osteoarthritis, treat the area of pain. Patient 65, they have lots of arthritis, right? But in a very in-depth explanation, but in minimal time, you have left lateral knee pain associated with weak abdominal stabilizers, weak left hip. So basically, I'm explaining what I found. That is the working diagnosis, because we're simply stating what we saw, what we observed. That's right, because when we put a label on it, we don't know if that's right. Just because they have a knee pain, we need to provide substance, especially when we're working with other practitioners, and especially if you're working with lawyers or any type of a case that has any type of legal flavor to it. Well, how do you know they had left knee osteoarthritis? Because you saw it on an x-ray, right? Everybody over the age 35 has some mild osteoarthritis. How do you know this was caused by that, right? So we need to provide context. Case 3. This one's a 36-year-old woman presents with acute low back pain in the left sacroiliac joint region with some left gluteal discomfort. So as I'm saying this, I'm painting a picture in your mind. That's what a clinical case study should do. Because otherwise, I'm just saying tree, car, fish, right? I'm explaining it. I'm painting that beautiful picture in your mind of the patient with left gluteal discomfort over the left SI joint. And the patient reports occasional pain extending to the knee, but not past it. The EXSTORE system reveals that the patient complains of left gluteal pain during gait assessment, so we omit the gait analysis due to pain. Due to acute pain, she's acute. She's unable to do resisted lumbar core stability. The rest of the lumbar body scan reveals that the SLR is unremarkable, as both sides are equally 50 degrees without pain. Gluteus medius and minimus and gluteus maximus are very weak bilaterally. Now, this patient is acute. So what this history tells us is that SLR, straight leg raise, is unremarkable. It's probably not a disc, although we can't rule that out. 2, the pain isn't past the knee, so it's likely posterior femorocutaneous nerve, which is a branch of the sciatic nerve, not the sciatic nerve itself, so less likely a nerve compression, which is great news. And then the fact that she has bilateral gluteus medius and minimus inhibition could be just to the fact that she's very jacked up, so to speak, and very acute. You'll have that. When someone's in acute pain, everything hurts. So just think how much we extracted from a minute or two. That's what paints the picture. Typical diagnosis is acute low back pain with sciatica. That's what it is, because any type of leg pain will say, well, patient has sciatica. Versus the truth, acute low back pain associated with very weak gluteus medius, minimus, maximus, and a deconditioned abdominal core. Focus on restoring inhibition in the abdominal obliques and transverse abdominis with the patient in the supine position, and so on and so forth. Now, one thing that was omitted here back in 2010 is the significance or potential for significance with a chronic systemic intervention, because this patient sounds a lot like could be chronic systemic, because I don't know what, I'm not giving enough information. This is a snapshot, right? But for all intents and purposes, this is an acute low back pain presentation without any competing conditions going on. This is going to show you one more, then we're going to get into 8 minutes of video. A 46-year-old weekend baseball player presents with pain in his right throwing shoulder. Pain is worse when he reaches behind his back to tuck his shirt into his trousers. That picture, That picture, guys, that picture is so much better than saying rotator cuff injury. How? Rotator cuff. How? He's tucking his baseball jersey into his trousers, just like Kevin Costner's dad from Field of Dreams. If you build it, remember that? Create that picture. Gait analysis reveals his right shoulder does not move very much at all compared to his left, which is swinging freely. The upper body scan reveals cervical extension and rotation is limited in both directions, and his external rotators of his rotator cuff are painful and weak upon testing. So in the movement, he can't tuck in his trousers, he can't tuck his shirt in, and when we're testing external rotators, we find that it's weak. Well, when you put your arm behind your back to tuck in your pants, you're using your internal rotators, but your external rotators are the antagonistic pairs, the opposites. And if they're tight, you can't properly do any internal rotation. And that came to light during the EXSTORE testing here. And this is what we learn in the EXSTORE in the live course. We learn all about antagonistic pairs. So just from someone tucking in their shirt, you could extract a plethora of information. Imagine that. So typically, this would be a typical diagnosis. Maybe the doctor would send him for an ultrasound, maybe physical therapy. Who knows? And the EXSTORE approach would be find what isn't working and simply correct it. In this case, focus on restoring inhibition of the external rotators, use myofascial work and acupuncture. You can use the motor points of the teres minor and supraspinatus. Listen, the approaches you can use are endless, and I mapped that out for you when you learn the EXSTORE system. But the point is, it's simplicity at your fingertips. Now, I'd like to show you a little bit of EXSTORE in action. That's why I wrote that. So this is just a glimpse of the lower extremity scan in action. The hip flexors, the abductors, or the extensors. So I push down and you push up. Go ahead. So I'm testing the psoas and the iliopsoas respectively. Push up. Push up. So we see here there's a weakness here. There's an inhibition. So I push down. You push up. Go ahead. Good. Push up. So the right side of the hip flexor and is strong here. So this is something significant. The right side, which I saw some dysfunction or some overcompensation during the runner's gait, but when I do the left side of the iliopsoas, go ahead, push up, there's a weakness. Now, as we're going to talk about shortly, we're going to talk about the tension, the lines of tension. There's torsional lines of tension, there's posterior lines of tension. We're going to explain that, and I'm going to tell you how this ties in to the inhibitions that the runner is facing. I'm going to go to the bottom here, and I'm going to test. I push in, you push out. I'm testing the TFL. Go ahead, push up, push up. So a little bit inhibited. She's providing me with some resistance. Go ahead, push up. It's much stronger. Go ahead, push up. So I'm doing the gluteus medius. When I'm doing this, I'm not going to explain it specifically because in order to explain the nuances of it, I recommend you read the manual, or those who have taken the course, you can see that it's what I'm demonstrating is really the crux of it, and I want you to understand how we assess and treat runners on a bigger scale and not just the EXSTORE system. I push in, you push out. Good. So there's some inhibition of the TFL, not really. There's definitely an inhibition of the iliopsoas. I'm going to have you lie on this side for me. So I'm testing the gluteus minimus here. So I hold that up, you hold that up, I push down, you push up, go ahead. Good. Lie on this side here. I push down, you push up, go ahead. Push up. So some inhibition here. You can tell this is the right gluteus minimus, and that's inhibited. So I'm going to have you lie on your stomach. So what we found so far is the left iliopsoas and the right gluteus minimus, that's inhibited. The last thing I'm going to test in the lower body scan is the gluteus maximus. So I'm going to have you lift your leg off the table. I push down, you push up, go ahead. That's strong. Go ahead, push up. that strong. As you'll find, most long distance runners will have very good gluteus maximus strength. And the reason is, even if they have injuries, the gluteus maximus can overcompensate for a lot of biomechanical imperfections. Very analogous to the deltoid in the shoulder. When you look at the deltoid of the shoulder, you can have 2 or 3 rotator cuff tears, but a well-developed deltoid can help make up for the glenohumeral biomechanical dysfunction. Great. I'm going to have you sit up now, and what we're going to do. All right, so that is a glimpse of the lower body EXSTORE scan. So I found what isn't working. Now it's time to correct it. And so how we approach the correction is using motor points. So there's different ways I could get those muscles activated. And so I forget why I choose these ones. I typically choose the path of least resistance to activate as many muscles as I can, because sometimes when you activate one muscle, for instance, the internal oblique, you can get a co-contraction of the quadratus lumborum, which also has a stabilizatory effect on the gluteus minimus. So any of those muscles were inhibited, you're going to see activation in those muscles. So let me take you here to show you the next step, so to speak, in terms of treatment. To give you a glimpse, we're going to go to 1232, where I think I'm working on the core. I'm working on the oblique. So I'm going to stop my video and I'm going to hit play. Doing okay? Mm-hmm. Is I'm going to stimulate the motor point of the internal oblique. Just let the arm just relax there. Because they run along the same fascial line. The internal oblique, I will tell you how to get it. I find the lateral line and I draw a line all the way down to the top of the iliac crest. And then I move 1 inch superior to that. And I advance the needle. And we're looking for some local stimulation here. And we get some really strong stimulation. Even if we back pan, doing okay? Mm-hmm. And even if we can then get a shot of the back, we can really see how we get some pelvic neuromodulation, because the internal oblique attaches to the ribs via the abdominal fascia. So we can really see that contraction happening. And here we're also getting some co-contraction of the transverse abdominis. So I do this in total for approximately 5 to 7 seconds, 6 or 7 times. Very good. What I want to do now is show you some simple myofascial release that I do. You doing okay? Mm-hmm. And here, as I follow all along the line, creating tension, finding tension. This is where I find some areas that are very sore. Doing okay? Mm-hmm. And I'm just cleaning this area right along the scapula. This in itself will improve a lot of the mechanical dysfunction. There's definitely an old shoulder injury here and a lot of scar tissue. Okay. Yeah. All right, so I stopped it there because I wanted to show you that's exactly what I do after I use the motor point. Get into some soft tissue, break up some adhesions. That's why after visit 1, when you apply this, instantly you see, patient sees, we all see tremendous results in mechanical dysfunction. The last part of the video I want to show you is typically what happens on visits 2 and 3 and moving forward, using a assortment of needles with the electro-acupuncture in the different techniques to break up scar tissue, to improve tissue function, and to improve perfusion and tissue health. And the whole point of this is that it happens faster. let me get to 3709. What's happening at 3709? This here is an excerpt from, I took this from the webinar, How to Treat Long Distance Runners. It's a long one. Very in-depth. All right, 3709. Here, let's start you at 3655. And provides a little bit of external rotation of the leg in this case. Doing okay? Mm-hmm. So what I do is I couple these together. What I do is I put one lead of the Ito here on the black, and the red I put on the TFL. And then what I do is it's on low frequency, 4, that means 4 here means 1.5 hertz. And I'm going to increase it now, and we're going to see some contraction. So perfect, we're getting co-contraction. You can see here the TFL is moving, and here the short head of the bicep is moving. And if I increase it, we move it even more. And so what's happening here, if we pan back, I want to show you, if you think of the TFL as a taut string, what's happening here, this is contracting in one direction, this is contracting in the other, and we're almost getting a torsion movement. If you look at the tissues, torsion movement, you see the needle itself here, these needles are moving in this direction because we have one force going this way and one force going this way. Now, what are these 4 needles for? These are in the surface, only a few millimeters, 3 to 4 millimeters in the anterior portion of the iliotibial tract. What I do is I clip the needles, one like so, and one like so, and I run this at high frequency, about 100 hertz. So this, we put it actually on medium frequency, and medium is 9, so we go to 9, which would be around here, and that would be between 80 and 150. Some of the Pantheons and other specific machines will allow you to be pinpoint. That is even better. This works extremely well, and I run this for 10 to 15 minutes. And the low frequency I run for about 10 minutes in the athlete. All right, that concludes the video presentation, and I really enjoyed that myself. That was from the Long Distance Runners webinar, very in-depth, but it shows you a snapshot of when we make pinpoint assessment and we assess for ourselves, we have more time to spend on treatment, and that's why we get better results, because we spend more time, more hands-on time per unit time than anybody else. Meaningful repetitions, meaningful time spent. Josh, are we going to roll into the Q&A?
Yes. Any questions? Please pop them in Q&A. We do have one in there now if you want to check it out.
Sure. So they're not in start. They're not in chat. ST joint, great question. ST joint stands for scapulothoracic joint. So it's basically the physiological joint where the scapula articulates with the ribs on the dorsum of the thorax. Scapulothoracic joint. Do you run high frequency and low frequency at the same time in the same treatment? In fact, sometimes I do, depending on the problem. Usually when I'm treating a combination of more of a complicated, different type of injury where we're dealing with pain, and I'll give you an example, frozen shoulder. Frozen shoulder, that happens a lot where we use high frequency and low frequency at the same time to combat pain and improve range of movement. Do you find it's too much stimulus for the person? Not if the person's chronic systemic, then yes, then we won't use that type of approach. Although it really depends. I really don't, I can tell right off the top if they're going to be a candidate for multiple stimulation, multiple frequencies at the same time. If they are, then I won't do it. I'll keep it simple. But usually we know, we can see it if they've got their affect, a lot of, just from their patient history, taking a lot of medications, not sleeping, a lot of conditions. But in most cases, it'll be, I do it a lot. Yeah. Again, it's like know your audience. If we know that it might be a problem, then we want to try different things. So if here's a word of advice, if anytime you think that stim is too much, then replace, decrease the amount of stim or time and replace it with hands-on soft tissue work. There's nothing better than hands-on soft tissue work. And that's part of the system, learning soft tissue work. All right, with some E-stim patients, a question is, the stim attenuates, great word, attenuates, and decreases, but for some, it increases. So I can explain that, yes. And some, it increases the contractions. I find when we are needling inside a very tight muscle and we have very minimal stimulation, we have a knot like this. We know acupuncture works on a relaxation reflex. So the needle goes in, and slowly the muscle starts to release. And in the science, in one of the articles that I quoted, it shows that the effects of acupuncture typically happen, I forget the time frame, 10 or 12 minutes into the visit itself with respect to modulation of the autonomic nervous system. Anyway, what I think happens, the needle goes in, it starts to release, and it's tap, tap, tap. And as the muscle releases, all of a sudden there's greater access to the motor nerve. And if that needle or that 2-needle technique is along the muscle belly, you're going to get an accentuated contraction. And I've had it too, where maybe the patient rings the bell or I come in and they're jumping. And they're like, I just started, Other thing can do it is they maybe move a bit, right? And change the position and angle of the contraction. That'll do it as well. Can you explain that? So using a Pantheon, it would be the same thing. Pantheon is just more specific, has more leads, more specific with frequencies.
Hey, Anthony?
Yes.
There was a question from Brent. Brent?
Yes. I'm sorry, I missed that. I did see it. I think I went past it in 1 second.
And Dennis, short answer is I did not even know that that was an option or not. I can look into it.
Brent, here it is. So if tennis elbow you treat with EXSTORE, does it usually clear up without motor points at the extensor forearm? Yes. Yes. Usually, and this is, let's say all things taking into consideration, like no external factors that are like, throwing us off, just plain mechanical. You'd go in, you find what isn't working. You probably would have serratus anterior inhibited, supraspinatus inhibited. You stimulate them with electro-acupuncture. You do some soft tissue work. Huge improvement in stability, huge improvement in range of motion. You then go locally to the arm itself. You might do an inline technique along the extensors, find a tight band. Maybe you're on visit 2 now. You would do some soft tissue work, maybe some jade stone, just light breaking, not jade where you leave marks, jade where you just create tension and break up surface tension. Do more soft tissue work. Maybe you tape it. Maybe you give them home exercises, and usually within 3 or 4 visits, they're a ton better. That was basically the Coles Note version of how it happens, but it's true. Another question, Kevin, as well. What exercise do you give a patient to activate serratus after stimulating an inhibited serratus? So actually, funny you should say that. And if you go on my Instagram, if you're on Instagram, because I posted it there, not that my Instagram following is huge because everyone knows it's not, but I posted a video of showing a pillowcase exercise that I give to patients Before I get started today with patients, I'm going to show you an exercise that's going to make your shoulder stronger and give you better posture. This will help you strengthen this muscle right here. It's called the serratus anterior. Simple. Get a pillowcase, put your hands in the corner of the pillowcase so that your hands are out, and then grasp it. Then find a wall. Oh, here's one. You place your forearms on the wall and you slide your arms up the wall, trying to always keep contact. And your serratus anterior muscles, your shoulders will go outward or protract. On the way down, I really like to embrace the negative because you start to contract your mid-scapular muscles or your trap. Oh, that feels good right there. And then I'm up again. And I'll do this for 5 repetitions, but I don't do this for 3 sets of 5 or 4 sets of 5. I do it for 5. And then later on in the day, I do 5 again. I do 30 to 40 per day. And my serratus anterior and my posture has never been better. Should patient feel the sensation from both black and red lead? Good question. Sometimes they do, sometimes they don't. They usually feel one more than the other. It's usually the black or the one that's distal. What's the difference between treatment for the chronic systemic? So Jennifer, in the course, we get into it extremely in depth, but we simplify it. So to simplify the treatment, it's not necessarily less stimulus. It's knowing what tissues to stimulate and what tissues not to stimulate. That's essentially the difference.